Good evening and a very warm welcome to our international audience to another educational series. Today, our topic of discussion is about pachychoroid diseases and especially polypoidal choroidal vasculopathy. In order to discuss this disease, we have again requested Professor Joaquin Alfredo Baffelli from Argentina. Professor Joaquin is chairman of Ophthalmology, National University of Rosario, Vice President, Argentinian Society of Vitreoretina, and he is a full professor and he has multiple publications to his credit. He's a teacher, mentor, and researcher, and he has contributed a lot. He's a member of American Academy of Ophthalmology, member of Argentinian Council of Ophthalmology, and Argentinian Society of Ophthalmology also. And he is a member of the board of directors of Pan American Association of Ophthalmology. We are very fortunate that Prof. Joaquin has given us time to educate our audience on this topic of pachychoroid diseases. So without further delay, I will request him to please present his talk.
Okay. Thank you very much, Dr. Anim, for your kind invitation and presentation. The topic today is pachychoroid spectrum disease and polypoidal choroidal vasculopathy especially. These are my disclosures. As you know, the choroid has 3 layers. Choriocapillaris, subtler is the middle, and the external layer is the Haller's layer. If you do unfast cuts with in OCT and geography, you can see in different levels, different images. In choriocapillaris, you can see like grainy sand. In the subtler layer, you can see like short-curved spaghetti. And in the Haller, with dominance of dark area because the bigger vessels in this layer. The choroidal thickness normal is between 280 and 290 approximately microns, decrease with the increase in age and actual length, difference not associated with gender, blood pressure as well as time of the day can change it, is thickest in the fovea, thinnest nasally, and can transiently increase in diseases like both Koyanagi arada and the multiple evanescent white dot syndrome, for example. These diseases have a pachychoroid phenotype, have common features between them. They are diffuse or focal increase in choroidal thickness, reduced tessellation, dilated outer choroidal vessels, attenuation of inner choroid overlying the pachy vessels, hyperpermeability on ICG, and the presence of pachyndrusems. Let me show you these features. One of them is diffuse or focal increase in choroidal thickness. You can see in the image, the thickness of choroid is more than 500. This thickening is especially in the external layer, in the Haller's layer. Other subtle change is reduced tessellation in areas of choroidal thickening. These are many few changes in the fundus side, and as you see in the images, there are drusen. The presence of pachy vessels can be diffusely or focally. Generally, they are vessels dilated and rectified, and generally they are venous. On OCT, in uncut, in cut and fast, you can see in the external layer the rectified and dilated venous vessels. Other feature is attenuation of inner choroid overlying pachy vessels. The attenuation is on the choriocapillaris layer. because the presence of Haller's layer Pachy vessels. Other feature is choroid vascular hyperpermeability on ICG angiography, especially present in later times, suggests possible choroidal ischemia, can be focal or punctata hyperfluorescence. These findings persist in eyes with CSC even after resolution of subretinal fluid, can be seen in the healthy fellow eye. And the other feature is the presence of pachydrusen. They are larger than 125 microns, scattered in the posterior pole, well-defined border, not show a tendency to aggregate, and don't have focal hyperpigmentation. With these features, there are some diseases that compose the pachychoroid disease spectrum. They are 7, maybe 8 types of different pathologies, and we will see one of them and some of them in the next. It's interesting because these diseases, this is an image from Dr. Friend from New York. These diseases can be lighter or heavier. Lighter, they are as pachychoroid pigment epitheliopathy, central serous chorioretinopathy, and focal choroidal excavation. They generally present in people between 30 and 40 years. Then with evolution, this kind of diseases can evolve to pachychoroid neovasculopathy. This is a heavier kind of the pachychoroid spectrum because has neovascularization. And then with evolution can be in polypoidal choroidal vasculopathy when the people has 50, 60, 70, or maybe 80 years. This image shows us maybe this is a dynamic process between the different types of diseases in the pachychoroid spectrum. One of them is PPE, and as you see in the images, you can see just very few changes in the fundus and in the autofluorescence, generally without drusen. This is another example of PPE. In the fundus eye, you can see very few changes. In the ICG, you can see hyperpermeability, and fast OCT, you can see the bigger venous vessels, and OCT, you can see the thickening of the choroids, obviously. In focal choroidal excavation is other light form, and this disease can be conforming type or non-conforming type. In the second, you can find hyporeflective space between neurosensory retina and pigment epithelium. Other type is pachychoroid peripapillar syndrome. In sum up, this disease is the same. It has the same changes than the diseases before, but all of them are around the optic nerve. Other very common form is central serous chorioretinopathy, CSC. It has serous retinal detachment with or without serous PD, young to middle-aged men, emetropic or hyperopic eyes. The exudation resolves in more than 80%, and recurrent exudations up to half. When we do fluorescein angiography, we can see the leakage point that is better seen in the late times of the fluorescein angiography. This is an example, a person with CSC, the affected eye and the fellow eye, both with the thickening choroid, and on the right, the normal people in control with normal thickness of the choroid. Many times you can see, always you can see the thickened choroid on OCT, and sometimes you can see the elongation of photoreceptor outer segments. These are the typical image of the acute CSC, and the others are typical images from chronic CSC. On the right, in the OCT, you can see a shell irregular pigment epithelium detachment and intraretinal fluid sometimes. Below, you can see with the chronicity, you can see the thinnest neurosensory retina and persistent fluid subretinal. And on the left, we can see the autofluorescence with the typical change called gravitational tracks, because the RPE alteration. When you have a patient with central seroscopic retinopathy chronic, you must suspect the presence of choroidal neovascularization. When the PED is hyporeflective, flat, irregular, generally is avascular and without neovascularization, choroidal neovascularization. But if the PED is hyperreflective or mixed, generally is associated with choroidal neovascularization. When the patient has neovascularization and you do a fluorescein angiography in the late time, you can see the undetermined image in the fluorescein angiography, as typical in the presence of neovascularization, choroidal neovascularization, occult choroidal neovascularization. If you do an ICG, in the early times, you can see the bigger vessels, venous vessels, and in the late ICG, you can see the typical plaque of the patients with choroidal neovascularization. In the last years, with the OCT angiography, we can see the neovascularization without any dye. Other form of the spectrum, this form is heavier in comparison with the before entities. This is pachychoroid neovasculopathy with the presence of neovascularization. PPE, FCE, and CSC may develop type 1 neovascularization with slow growing. The neovascularization is always type 1 under the RPE. PCV may develop in the fluorescein angiography a late leakage with undetermined origin, like occult CNV can be seen as we've seen before. As we've seen before too, ICG angiography, late staining in form of plaque. And this disease do not exhibit descending tracks and autofluorescence. This is an example with both eyes, a man with 68 years old, right eye 20/60 and left eye 20/25, with many few changes in the fundus eye. On ICT angiography, both eyes present hyperpermeability. In the OCT angiography, the right eye present neovascularization, and the left eye, without symptoms, present the neovascularization too. In this case, this is called quiescent neovascularization and don't need any treatment. Finally, PCB is a variant of type 1 neovascularization under the RPE. It was first described in the 90s by Januzzi. PCB is seen particularly in Asian people. Disturbance of endochoroidal circulation and presence of orange nodules beneath the retina. This is a typical images of the PCB, but it isn't polypoidal because it's aneurismal changes. It isn't choroidal because it's between RPE and Bruch's membrane, and it isn't vasculopathy because it's neovasculopathy. Clinically, we can classify this kind of disease in quiescent with many few changes, exudative or hemorrhagic type. It's very important in these patients to do the ICG angiography because we can see some changes important for the diagnosis. One of them is hyperfluorescence halo, but there are two many important changes. They are hyperfluorescent hotspot, they are the polyps, and the branching vascular network. This is the real neovascularization. The PCB can be classified in two types. Type 1 with predominance of the branching vascular network, and type 2 with predominance of the polyps. It's important because generally the treatment of PCB is a mix between anti-angiogenics and photodynamic therapy. If you have a patient with the features like on the left, maybe the anti-angiogenics can be the better option. But if you have a patient with the features like on the right, with the polyps predominance, maybe the photodynamic therapy can be the better option. OCT is very important in the patients with PCB because it shows us thickened choroid, subretinal fluid sometimes intraretinal fluid. It shows us PED, pigment epithelium detachment, BVM, branching vascular network, and the double layer sign. In the images, you can see one type of PED is some thumb-like protrusion. This represents the presence of the polyps in the images. You can see the other form of the PED is flat, irregular, and shell form of PED, and in this case, the PED represent the real neovascularization, branching vascular neovascularization, and this is the double layer sign. This is an example, a final example with the thumb-like protrusion that in the polyp zone, the shell irregular flat PED in the branching vascular network zone, and obviously the presence of Pachy vessels. In this case, with OCT angiography, we can see the polyps and the branching vascular network. In this other example, we can see the neovascularization on the OCT angiography. On the right, in the unfast cut, we can see in the layer, in the halo layer, the bigger venous vessels, and below in the OCT, we can see the thickness, great thickness of the choroid, and the two types of the PED, the thumb-like, and the shallow irregular PED. For the future, we have challenges to face, trying to avoid switching from the non-neovascular pachychoroid diseases entities. This is the lightest form, PPE, CSC, FCE, and PPS, to the heavier neovascular variants as PCN and PCB. Genetic and environmental factors, more accurate quantification of choriocapillaries thickness and blood flow, and improve the access for the whole population to ICG and PDT until there are diagnosis methods and more effective treatments. Yes, that's all, and thank you very much for your attention.
Well, Prof, it was a very interesting talk, and you explained pachychoroid diseases in great detail, especially polypoidal choroidal vasculopathy. Prof, one question. Nowadays, everybody is talking about OCT angio. Of course, new thing, and people are using. But what do you think the role of indocyanine green angiography, ICGA, as compared to OCTA in these pachychoroid diseases, Prof? Kindly guide about it.
Yes, I think both types of both methods are very, very good, but unfortunately, in our countries, we don't have ICG angiography, or is very difficult. But as you see before, the images in PCB with ICG angiography are very, very good. Obviously, with OCTA, you can you have the advantage without dye, and many times you can see the polyps, not always, but it's very good to see the branching vascular network. I think that if you can, both methods is better for our patients.
Well, thank you, Prof, for this great presentation. And I know you are just have some health issues, but in spite of that, you prepared this lecture and agreed to educate our international audience. I want to thank you on the behalf of your all virtual students who will be watching and getting benefited from your this knowledge and experience. So we are looking forward to more learning sessions from a scholar like you. And I also want to thank Mariana for assisting us like always. So thank you, ma'am, also.
Thank you.
Thank you. It was a pleasure for us.
Thank you, Prof. Goodbye.
Goodbye.